Hello everyone, welcome back. I'm Dr. Raihan Falari, and it's a pleasure to have you join me for today's lecture on the osteology of the lower limb. So together, we'll be exploring the fascinating structure and anatomy of the bones that support the movement and bear the weight of the body. So let's dive right in. So by the end of this lecture, you'll be able to identify and describe the bones of the lower limb. You'll be able to explain the structural features and attach this to their functional significance. You'll be able to relate this to common clinical conditions. And we'll also touch on developmental and anatomical variations to have a complete understanding. So as an overview, here is what the lower limb looks like, the entire of this lower extremity, and these are the bones that make it up. So we have from each side, you have the pelvic bone, all right, which is made up of three bones that we'll come to address later. Then you have in the thigh region, in this thigh region, you have this bone known as the femur. And then you have this joint known as the knee joint, where you also have an additional bone, the patella. Then in this leg region, you have two bones, and that's the tibia and fibula. And in the ankle region, you have what is known as the tarsal bones, okay, in the ankle region. Then you have in the foot proper, the metatarsals and the phalanges, which make up the digits of the toes. So, but when we say pelvic girdle, that refers to the bony ring that is formed by both pelvic bones, that's both hip bones, okay, when we consider both together, along with the sacrum. So it's the bony ring that is formed by the two pelvic bones considered together, along with the sacrum in the middle. And the sacrum is that triangular bone at the base of the spine. So it's the pelvic girdle apparently consists of the two pelvic bones and the sacrum, which connects the spinal column to the pelvis. So both of these, all of these structures, the pelvic girdle anchors the lower limbs, the axial skeleton, while the bones of the thigh, leg, and foot uh, provide mobility and stability. So this structure collectively supports the weight bearing and the locomotion of the body. So on each side of the pelvis consists of a single bone. So it used to be known as the innominate bone. It's also referred to as the hip bone. So it is a single bone. In adults, it is formed by the fusion of three main bones, and that's the ilium, which is this broad flaring portion that forms the upper part of the hip bone, ilium. And take note of the spelling, ilium. It's different from ileum, which is a part of the small intestine, the duodenum, the jejunum, and the ileum. So that's ile, but this is ili, referring to this bone and this component of the hip bone. So here is the ilium, and then the pubic bone or the pelvic bone also has the ischium, which is the lower posterior part that you sit on, and then you have the pubis, pubis. So if you convert this to an adjective, then it becomes pubic. So that would be you referring to a structure like the pubic tubercle here. But referring to the bone on its own, you refer to it as the pubis or the pubic bone in its entirety. So we'll be going through a number of the clinical features on this bone. So right here, you are looking at the external surface of the pelvic bone, referred to as the lateral view. So here is when you look at the pelvic bone from the outside, on the lateral side. And when you flip it back, this is what you see on the medial view. So let's start with the lateral side. You can see, you need to first of all appreciate the anterior part of the individual and the posterior part of the individual. Remember, this bone remains a landmark to appreciate the direction of the pelvis, at least for starters. We mentioned that this ischium, the ischial bone, is the bone on which you sit. So this is naturally on the back. So this is the posterior part, while this region will be the anterior part of the ulna of this pelvis, while this is the posterior part of the individual. So we're looking at this lateral feature. So appreciating this as anterior and this as posterior, we see on the top here, this region known as the iliac crest, okay? And the crest of something is the topmost part of it. So on this iliac crest, it has an outer lip, which is this outer margin, that's the outer lip. And then on the inside, on the flip side, you can see the medial lip, which you can appreciate on this medial side. It's not readily seen on this lateral view. So in between the outer and the inner lip, you have what is called the intermediate zone. All right. So all of this make up the iliac crest. And take note of this tuberculum, which is this outpouching on the outer lip. All right. Then we come down here. So the iliac crest ends up, it terminates into a spiny region on the anterior. Okay, it terminates anteriorly into a spiny region, a spine-like region. And this spine, there are 4 of such spines around the ilium. Here is a spine, here is another spine, here is another spine on the posterior, here is another spine. So naturally, you can differentiate these 4 spines by regarding 2 of them as anterior spines, 2 of them as posterior spine. So from between the both anterior spines, one is above and one is below. So that's why this is safely referred to as the anterior superior iliac spine. You may want to combine both words together by calling it anterior superior iliac spine, or you can separate them as anterior superior iliac spine. It's a popular landmark in lower limb osteology. So it is also acronymed as ASIS, ASIS, anterior superior iliac spine, and this becomes what? The anterior inferior iliac spine. So on the flip side, the back region, this is the posterior superior iliac spine, and then the posterior inferior iliac spine. So let's move a little into the center now. So notice that on this region of the ilium, there are two main let's say so there is this region that is wing-like from here down here. So all of this is considered the wing, otherwise known as the ala of the ilium. Okay, so this is the ala of the ilium. This is the ala of the ilium. It's wing-like, and you could imagine it's more like a hand fan, you know, that you could use to blow something. So this is the ala of the ilium, and this surface of the ala is known as the gluteal surface, because it's on this surface that you have attachment of the gluteal muscles. Anything gluteal now is apparently referring to the buttocks. So there are muscles there. So these muscles get to attach to this surface and to these lines as well. So here is the gluteal surface of the ala of the iliac bone, and the other part of the iliac bone that is not part of the ala includes the body of the ilium, which is right here, and then you have part of that then contributing to the formation of the acetabulum, which we'll come to in a minute. But before we leave the ala, you'll notice a number of lines, 3 significant lines. So here is one line, here is another line, and here is another line. So how do we tell this line apart? They all are on the gluteal surface, and for that reason they are all referred to as the gluteal lines, the 3 gluteal lines. Now this one is the most inferior, so we can refer to this as the inferior gluteal line, and this is the most So this as well as this are superior, okay, but we need to find a different way to name them. So one of them extends far anteriorly, and that's why it's rather referred to as the anterior gluteal line, because it's the most anteriorly protruding, anteriorly extending, and this one is referred to as the posterior gluteal line. So these three are the gluteal lines. And you see that between the body of the ilium and the ala of the ilium, you see this notch posteriorly that is related to the sciatic nerve. So it's called the greater sciatic notch, the greater sciatic notch. And so let's move on now. So you see the tapering part of the ilium goes to contribute towards the formation of this major center you see in the pelvis, and that is the acetabulum. So here is the acetabulum. It is formed by contribution from the three bones that we have mentioned. So superiorly, the iliac bone, posteriorly or posterior inferiorly, it's contributed to by the ischial bone, and then anterior inferiorly it's contributed to by the pubic bone. So this concludes our talk on the lateral part of the iliac bone. Before we go to the other bones, let's appreciate the medial part, things that we can see on the medial view. So you can readily appreciate the inner lip of the iliac crest on the medial surface. Here you can see the intermediate zone as well. So here is the iliac fossa of the wing of the ilium, or the wing of the iliac bone, right? So the external surface of that will be the gluteal surface. The internal surface of this ala is the iliac fossa. And you can appreciate the anterior superior iliac spine still here, and then the anterior inferior iliac spine. You can also see the posterior superior iliac spine and posterior inferior iliac spine. Now there is this line that runs across right here, and that is the arcuate line, so named because of its shape. So that serves as the transition zone between the body of the ilium and the ala, or the wing of the ilium on the medial surface, on the medial side. So here is the body of the ilium again, and then you can appreciate the greater sciatic notch here from the medial part. Remember, the ilium, in order to contribute to the formation, the pelvic bone, in order to form the pelvic girdle, we need to consider it along with the sacrum, the sacral bone, right? So there, the point of attachment of the sacral bone to the two ilia. So both iliac bones connect or attach medially to the sacral bone. So here is the point of attachment known as the articular surface for the sacrum. Right, this is the articular surface for the sacrum. So apparently this is the right ilium, the right pelvic bone, and this is the right ilium, right? Because this is the anterior region and this is the posterior of the individual. So looking at it from this medial surface, so here is the point where the sacral bone attaches. And going inferior now, let's look at the ilium, the ischium, the ischial bone now. The ischium, you can notice it has a spine here as well, a spiny projection, and this region of it is known as the ischial spine, okay? And you then have the lesser sciatic notch just inferior to the ischial spine. So the greater sciatic notch, you find that in the iliac bone. This lesser sciatic notch, you find that in the ischial bone. And then you can see this rough part of the ilium, of the ischium on which we sit, and that is the tuberosity of the ischium, known as the ischial tuberosity. Now, we have a part of the ischial bone that is projecting anteriorly in order to form the inferior margin of this round hole you have here. By the way, this round hole is known as the obturator foramen, through which you have the obturator nerve emerge amongst other structures. So the region is named obturator. So the foramen is also referred to as the obturator foramen. So forming the inferior margin of this obturator foramen are two bones, okay, which come together to merge. So they all contribute an arm. Each of those bones contributes an arm which meets in the center to form the inferior margin of this foramen. Each of these arms is referred to as a ramus. Okay, so the ramus contributed by the ischial bone is known as the ramus of the ischium or ischial ramus, and then we have the pubic ramus, and there are two of such rami in the pubis. One is on the inferior and the other one is on the superior part. So this is the inferior pubic ramus and this is the superior pubic ramus. And then on the anterior region, you find a tubercle around the pubis. Okay, so that is referred to as the pubic tubercle. Now, this is the obturator foramen, and then we referred also to this large center, this large centric structure. It's known as the acetabulum. This is the acetabulum. Okay, so it has a lunate surface, so named because of its moon shape, its moon-like shape. So here is the margin of the acetabulum. Okay, this is the margin of the acetabulum, and this is the part that receives the head of the humerus, while allowing the transfer of weight from the torso down to the lower limbs. So this is where the head of the humerus attaches, this acetabulum. So this is the margin of the acetabulum, known as the limbus of the acetabulum, and then here is referred to as the notch of the acetabulum. So with this, we complete appreciation of the lateral view, and then the corresponding medial view reveals the superior ramus of the pubis more clearly seen. Okay, and then you have this pectineal line on the superior border of the pubic bone. So you appreciate better the obturator foramen having a groove above it at the superior part, and this is known as the obturator groove. So and then on the inferior part you can see the inferior pubic ramus that meets up with the ischial ramus, okay, to form the inferior margin of the obturator foramen. You see the ischial tuberosity here again, and here is the body of the ischium, which is seen here. It's also this region. It's deep, yeah, so it's right here. So the external surface of that is the tuberosity, and you have the body of the ischium appreciated here. You have the tuberosity here. You can see again the lesser sciatic notch on this medial surface, the ischial spine. Yeah, okay. So here as well is here is the body of the ilium, which we appreciated earlier. And an important feature, landmark on this pubic bone, after seeing the tubercle on the top, is the region. Remember, we have two pelvic bones, right? So they meet posteriorly by attaching to the sacral bone, right? While anteriorly they meet by both pubic bones joining together. So there is a cartilage that joins both the right pubis with the left pubis. We'll see the complete skeleton again in subsequent slides. So this is known as the pubic symphysis. This pubic symphysis therefore has a surface for its attachment on the right and the left pubic bone. So here is the surface for the pubic symphysis, and it's known as the symphysial surface. So with this, we appreciate better the, the landmarks on the pelvic bone. We see that the pelvic bone is consists of, it's a single bone, right? That consists of the fusion, or it's made by the fusion of these three bones. And we have appreciated a number of landmarks, including the iliac crest, the ASIS, the PSIS, the obturator foramen, the acetabulum, amongst others. So clinically, fractures in the pelvic ring or the acetabulum, or even a dysplasia in the acetabulum, as we'll see in subsequent slide, so can affect the weight transfer from the axial skeleton down to the lower limb. So here we would like to appreciate differences between the male and female pelvis, and this is achieved through a number of parameters. So when you look at the general structure, a male pelvis is typically more heavy and thicker than a female pelvis. So take note of this sign. These are genetic signs. These are signs that are used in genetics also to indicate male. This little circle and an arrow at the top right, and then you have a circle with an inferior cross indicating a female. It's a common symbol, so that's what is used here again and here. So take note of that. So generally, the male pelvis is thicker and heavier, while the female pelvis is thinner and lighter. So you need to see both to be able to appreciate the difference. You don't appreciate what is thick until you see what is thinner. All right, yeah. So also when you look at the greater pelvis, which is this expanse here, largely formed by the pelvic wing, or the ala of the pelvis, formed by the iliac bone. Okay, so the greater pelvis in females, this is the female pelvis, it's usually shallow, while in males it's usually deep. Okay, so the lesser pelvis now is the part that is deep to the pelvic inlet. We talked about the pelvic ring the other time. So the lesser pelvis is the part that is deep to that, and in males it's usually narrow and deep because it's narrow, while in females it's usually wider and not as deep as in males, so it's usually shallow. Why is that? You can readily imagine that that's to aid childbirth. Okay, so in females it's shallow, that means it's not so long, and then it is wide to be able to accommodate the child during obstetrics. By the way, obstetrics refers to the process of childbirth, like we mentioned in the physical class, while gynecology refers to the basic functionality of the woman. So that's why you have the common terminology ONT. That's just by the way. The pelvic inlet, which is the superior pelvic aperture, okay, where you have the ring, it is heart-shaped in males, right? While in females, it's usually more rounded and oval in shape. In males, it has this heart shape that is aided by the sacral promontory. Then the pelvic outlet on the other end that's the inferior pelvic aperture. Okay, the pelvic outlet is comparatively smaller in males, while in females is comparatively larger. So that's also to give an obstetric advantage. There is the pubic arch, the pubic arch, and the subpubic angle. So the arc and then the subpubic angle. So the arch is usually narrow in males. So since the pelvis is generally narrow in males, while in females the pelvis is wide, and for that reason the pubic arch is also wide. Okay, so here is for the female. You can see it's wider than that of the male. The obturator foramen, which we have seen earlier, in males it's usually round, while in female, because of the generally wide disposition of the pelvis, the obturator foramen is oval in shape. It couldn't sustain the kind of roundness that you have in the males. And then the acetabulum, which we saw earlier. So in males, it's usually larger, while in females, it's usually smaller. So that marks a difference between male and female pelvis. So on this slide, trying to explain that the pelvis is categorized into four main types based on the shape and dimensions. So it's referred to as android, gynecoid, anthropoid, and the platypeloid. Android, gynecoid, anthropoid, and the platypeloid. So the android pelvis is characterized by a heart-shaped, you know, a heart-shaped pelvic inlet and a narrow transverse diameter, and it usually has a reduced pelvic outlet, which can hinder, fetal descent and increase the likelihood of operative delivery of the woman having to go through operation. So this is android, and like the name suggests, it's typically expected in males. So it's an android when it's this heart-shaped, okay. And then once the pelvic outlet is reduced, that's naturally called hinder the descent of the child. Okay. So secondly, we have the gynecoid pelvis, and like the name suggests, it's the it looks more like the female, the typical female pelvis. So in its case, it's the most common type and ideal for vaginal delivery. Vaginal delivery means without needing to go through cesarean section, because once a woman's pelvis is not as gynecoid as it should, such a woman needs to be aided through operative delivery. So it's the most common type actually, and it's ideal for vaginal delivery. And it has rounded pelvic inlet, as you can see here, okay, and a wide transverse diameter, as well as a spacious pelvic outlet. So these features allow for optimal passage of the fetus during labor. Thirdly, we have the anthropoid. The anthropoid pelvis. This is an oval-shaped pelvis that has an oval-shaped inlet with a longer anterior-posterior diameter, as you can appreciate here. So the anterior-posterior diameter is much longer, and this favors the occiput posterior fetal positioning, but generally it allows vaginal delivery as well. So what you have the occiput, when the occiput of the child, the back of the child's head, is directed towards the posterior part, this makes it easy. In this point, in that case, the woman is able to deliver the child through the vagina. And then fourthly, we have the platypeloid. The platypeloid pelvis features a kidney-shaped, pelvic inlet with a wide transverse diameter but a narrow anterior-posterior dimension. So this often obstructs fetal descent, leading to a prolonged labor or the need for a cesarean section thereafter ensue. So now let's move into the pelvic diameters, which are critical, for understanding the passage of the fetus during the childbirth. First of all, we'll talk about the pelvic inlet diameter, and I need you to pay attention. Let me try and change my cursor to something that takes less space, perhaps a pen. Okay, yes. So here, the transverse diameter, right? The transverse diameter refers to, and it's been labeled as number 1 here when you look closely. Okay, so the transverse diameter usually measures 13.5 to 14 centimeter, and it's the widest dimension on the pelvic inlet. It spans the widest horizontal dimension of the pelvic inlet between the iliopectineal lines that we saw earlier, between both the iliopectineal lines. So it determines the lateral space for fetal entry into the pelvic cavity. Next are the oblique diameters, and we have 2 of them, oblique 1 and oblique 2. So as for oblique 1, that is labeled 2 here, Okay, the oblique 1 extends diagonally across the inlet, and it's just the opposite for the oblique 2. So these are measured between the sacroiliac joints, the joint between the sacrum and the ilium. So from the sacroiliac joint and the contralateral iliopectineal eminence that we used for the transverse diameter area. So these are the oblique diameter. So the oblique diameter 1 is the one that runs from the right the right sacroiliac joint, that uses the right sacroiliac joint, and it's usually between 12 and 12.5 centimeter. And then the oblique diameter 2 is the one that utilizes the left sacroiliac joint to the contralateral iliopectineal line, and that usually measures slightly lower diameter than oblique 1, between 11.5 and 12 centimeter. Next is the anatomical conjugate. And the anatomical conjugate, usually at 12 centimeter, it spans the sacral promontory, and that is labeled 4 here. Okay, so that's the anatomical conjugate. It spans from the sacral promontory here down to the pubic symphysis, the upper pubic symphysis. So from the sacral promontory to the upper border of the pubic symphysis. So this is important in assessing the anterior posterior space that the child will be able to pass through. Okay. Now, next is the true conjugate, which is labeled 5, and you find that somewhere around here. Yeah, so it's right here, the number 5. You pay attention, it looks quite tiny, but sorry, I couldn't make it much bigger. So it's only slightly different from the anatomical conjugate in the sense that it's in its own case, the true conjugate is ending at the posterior border, the posterior surface of the pubic symphysis, right here. So the true conjugate is slightly shorter for this reason, at 11.5 centimeter. So it's an important tool for assessing fetal passage as well. So it measures from the sacral promontory, the same sacral promontory, down to the posterior border of the posterior surface of the pubic symphysis. This is the minimum anterior posterior dimension that is required for the fetal head to pass. So it plays a lot of role. And lastly, we have the diagonal conjugate, which usually measures around 13 centimeter. So this is labeled 6 here. Okay, and this runs also from the sacral promontory, but rather than ending on the pubic symphysis superior, it extends from that promontory down to the sacral, to the lower border of the pubic symphysis, and it's clinically measurable. Okay, so that makes it diagonal and as a conjugate. So these are the diameters for the pelvic inlet. So now to the pelvic outlet. The pelvic outlet has uh, 3 main diameters that we're interested in. So starting with this one labeled as number 7, that's the straight conjugate. So it spans from the coccyx right here down to the pubic symphysis, and it's usually between 9.5 and 10 centimeters. So the flexibility of this diameter during labor influences how the fetus is going to pass. All right, so that's the straight conjugate. And as for the median conjugate, which usually measures 11.5, which represents the narrowest anterior-posterior distance. Okay, it's also here represented. And finally, the interspinous diameter. So it's between the two spines. It's between the two spines of the ischium. So between the two ischial spines. Okay, between the two ischial spines, and it's a critical narrowest transverse point in the pelvis. So it's also critical for. So there are also other dimensions which we can be interested in, particularly the intercristal distance, which is running between both crests, between both iliac crests. So it measures approximately 29 centimeter. It's the widest point between the iliac crests. And then you have the external conjugate, which usually measures around 20 centimeters, and that provides the external estimate of the pelvic size. So it extends from the lower lumbar spine, from the lower lumbar spine to the upper pubic symphysis, from the lower lumbar spine down to the upper pubic symphysis. So that's the what is referred to as the external conjugate. So all of this movement, all of these diameters, these measurements are very essential for obstetric assessment, and it's the way to ensure proper evaluation of pelvic adequacy for delivery. So going forward, the femur is right here. We are going into the thigh region now, and the femur is the longest and strongest bone of the body. So proximally, it attaches the the acetabulum via its head right here, right, and it's supported by the neck, okay, which is prone to fractures, especially in the elderly. So we also have the trochanters, the greater trochanter here, and then the lesser trochanter here. So both trochanters serve as attachment site for muscles as well. So distally, the femur forms the knee joint, where fractures can impact weight bearing and knee function as well. So this is the part that attaches to the patella, and then you have the condylar region, attaching to the lower bones, that's the tibia in particular. Okay, all of this should then form um, the knee joint. So to appreciate this further, let's look deeper. Here is the anterior surface of the femur. Let me use my laser now. Yeah, so here is the anterior surface of the femur. So this same femur, which is the right femur now, when you flip it over, this is the posterior surface of the same femur. So here's the right femur, and that means when you're looking at this, you're looking at the right side of the person. When you're looking at this, here will be the right side, and here will be the left. So here is the right femur. So here is the greater trochanter. Okay, there's a greater trochanter, and here is the lesser trochanter. Here is the neck of the femur, here is the head of the femur, and here is a fovea, which is like an indentation, for the attachment of the ligament of the head. So yeah, and down this is considered the shaft, okay, of the femur, and here is the inferior part of the femur, and particularly here are the condyles. So here are the condyles. So here is the lateral condyle, and here is the medial condyle. And this region is the surface for the attachment of the patella. So that's why it's called the patella surface. So this broken line you're seeing here is a line of reflection of the synovial membrane, that contributes to the formation of the knee joint. All right, so now this is the condyle. The part of the condyle that is protruding out here, that is above the condyle here, is called the epicondyle. So here is the medial epicondyle. Remember, this is the left side of this right femur. So here is the medial part. This is the part that is closer to the person's midline. Okay, and here is the lateral epicondyle. Right, and this tubercle here is the adductor tubercle. Adductor tubercle. So looking at the left, looking at the posterior surface of the same bone, again, here is the trochanter, the greater trochanter, okay, and then you have this fossa that is deep to this greater trochanter is known as the trochanteric fossa, the fossa that is deep to this trochanter, right? And then you have the neck. Again, here is the head, and here is the fovea for the ligament of the head. Yeah, so there is this crest that runs from the greater trochanter down to the lesser trochanter, and that is known as the intertrochanteric crest. Intratrochanteric crest. So this part of it is known as the calcar, right? The calcar. And here is the lesser trochanter again. Now, here is the pectineal line. Here is the pectineal line. Let me change the cursor to a pen. We're getting into more minute details now. So here is the lesser trochanter. So here, this line is the pectineal line. All right. And here again is the gluteal tuberosity for the attachment of gluteal muscles. Right. So here is the gluteal tuberosity. Now we have what is called linea aspera. The linea aspera. So the linear aspera is so named because it is rough. It's a line, linear from Latin. Linear means line, and aspera means rough. So it's this rough ridge you find, this longitudinal ridge that you find on the posterior side of the femur. So it branches out proximally into these two lines known as the medial lip, which may also be referred to as the spiral line, and then it branches into this lateral lip, could also be referred to as the gluteal um, uh, the, the gluteal line. All right, it's referred to as the gluteal line. So this gluteal tuberosity is more like branching out of the linea aspera. So some sources also consider this pectineal line as the third branch from the linea aspera. Yeah, so that is that. So, and then you find it bifurcating again in the distal end, to contribute to the formation of the respective epicondylar ridges. So you also have this nutrient foramen, which is an opening that allows for the passage of blood vessels from within the in and out of the bone, which also contributes to the nourishment of the bone and contributing to its structural stability. So with this, we've appreciated the proximal end of the femur, containing the head, the neck, the greater trochanter, the lesser trochanter, and other structures. We've appreciated the shafts containing the linea aspera and nutrient foramina. Yeah, the distal end, we've seen the medial and lateral epicondyle. Then the intercondylar fossa. So the intercondylar fossa is right here. Is this fossa you have between the two condyles? It's more appreciated on the posterior view. I think that's how we skip that. And then the patellar surface on the anterior. Okay, so so these structures clinically uh, fracture is a possibility, is a common thing in the neck of the femur in particular. And there is also the Garden classification, which classifies femoral surgical neck fractures based on the level of displacement and the level of fracture that happens in that surgical neck. So it's categorizes them into type 1, type 2, type 3, type 4. So yeah, and then the shaft of the femur also would get fractured down here. Okay, so most of the structures we have seen in the previous slide, and there is hardly any of it that is new. But the reason why I added this is particularly to appreciate the cross section. So if the femur, you see again the association or the connection, the relation between the two iliac bones, right, and where they join with the sacrum in the middle, and then you see the pubic symphysis bringing together both pubic bones, right? And here is the femur. So when the femur is cut at this point, and then this area is the anterior, and then this is the posterior. So it's like cutting it and flipping it anyway. So here, if this is the anterior and this is the posterior, then this will be the anterior surface of the femur, while this is the posterior surface, and we already appreciated the linear aspera, right, on the posterior surface. So then it has a medial margin and then a lateral margin. Okay, and then because you then have a relatively smooth expanse between the medial margin and the linear aspera or the posterior part, so the entirety of this area is referred to as the medial surface. So it has an anterior surface, medial surface, and then a lateral surface. Okay, that's in the cross section of the femur. So we saw the intertrochanteric crest previously, and then the posterior surface of the proximal femur, the gluteal tuberosity, the pectineal line, the pectineal line, and then the spiral line, which branches out of the linear aspera. So linear aspera here, and then the gluteal tuberosity you have here. Okay. So we can further appreciate in this additional picture the head and then the tubercle, the tubercle of the femur next to the greater trochanter. Okay, and then you have the trochanteric fossa around here. So attachment to different muscles are also highlighted. You have the intratrochanteric line, which we've seen before, the lesser trochanter, the shaft, and down here the spiral line that branched out of the linear aspera is here again, the lesser trochanter. So here is a quadrate tubercle. Okay, the quadrate tubercle, and then we have the trochanteric fossa deep to the greater trochanter. You can see the fovea for the attachment of the ligament of the head here. You see some other muscular attachments too around here. So here is for the gluteus maximus, gluteus minimus, and here for the gluteus medius. So intratrochanteric crest is visible here again, the gluteal tuberosity as it branched out of the linear aspera, then the spiral line, the spiral line, and here, that quadrate tubercle is here again. So these are just to bring it further into context, the different parts of the femur. So we appreciated this already. So we'll just go into the angulations. So let's discuss some key clinical and anatomical aspects of hip and the femur before we go to the knee joint, the patella, and the bones you have in the leg. So the angle of inclination, it's particularly we are referring to the angle between the shaft and the neck and the head, so to speak, the neck and the femur. So it's typically about 125 degrees in adults. In adults, you have it as 125 degrees when you get the laser. And but in kids, in 3-year-old, for example, the angle of inclination was longer, so it starts to decrease as a person ages. The angle of inclination starts to decrease as the person ages. So here is angle of inclination in adult, and here it is in old age. It has reduced further to about 120 degrees. So when there is alteration in the normal conditions, the normal angulation of the cervical of the neck to the shaft, it can lead to conditions like coxa vara and coxa valga. Coxa vara refers to a decreased angulation, as you can see here, while coxa valga, it refers to an increased angulation. So both of these affect the gait and the stability of the hip. So once an individual has a variant angulation from the normal ones according to the respective age, then it comes down with these problems. Also, rickets and osteomalacia, they are both clinical conditions that we need to be aware of. So both of them are, metabolic bone disorders that result from vitamin D deficiency. Usually leads to weak bones and skeletal deformities. So in kids, rickets will lead to bowing of long bones. Okay, while in adults you have osteomalacia, which results in bone pain and fractures. So it's important that we put this into perspective while we talk about the proximal end of the femur, as well as their connection with the hip. Also, we can a possibility could be osteoporosis in elderlies, where you have fractures happening. So it's a common thing in elderly individuals because their bones become fragile and causes fracture, and it's often leading to a lot of falls. So these fractures are really a significant cause of morbidity, and it usually necessitates surgical intervention in adults. So we could also have congenital dislocation of the hips. So it's a common birth defect that is more common in female infants. So you either have the acetabulum failing to form completely, or you have the ligaments of the hip being too loose. So either way, it occurs due to incomplete formation of the acetabulum or the lax hip joint ligaments. And early treatment involves providing splints, you know, providing splints to or harness of straps to hold the femur in its proper position in order to promote normal joint development. Another possible condition is torsion of the femur, as it's here. So it refers to the twist along the longitudinal axis, of the femur. Twist around that longitudinal axis. So it's the femoral shaft now that is that remains more like stationary, and then you have the neck and the head twisting around it. So it's measured as the angle between the femoral neck and the transverse axis of the knee. So it's when torsion happens, it's an abnormal thing, and it affects lower limb alignment and gaits. Right. We also have the Rosa-Nelaton's line, so which is a clinical reference line drawn from the ASIS to the ischial tuberosity. Okay, so whenever there is hip dislocations or femoral neck fractures, the greater trochanter lies above this line. This greater trochanter, you can see, is currently below the line in normal individual. So, but when dislocations happen or the neck gets fractured, the greater trochanter line goes above this line. The greater trochanter moves above this line, serving as a diagnostic indicator. So these anatomical and clinical insights will help in diagnosing and managing hip and femoral conditions effectively. Okay, so the patella, it's actually the largest sesamoid bone that you have in the body. So it's embedded in the quadriceps tendon at the knee. Okay, it protects the knee joint as well, and it increases the leverage of the quadriceps muscles, right? So there could be a number of clinical issues around it, but let's appreciate the structure of it anatomically again. So when you remove the patella, this is what it looks like. And here is the base of it. Here is the apex. Okay. And because this is the medial border and this is the lateral border, will you say this is the right patella or the left patella? Yeah, this is the lateral and this is the medial. So that means this is the left patella, the patella of the left leg, and that's what is written here. Okay, so it's also known as the kneecap. So on the outer surface or the anterior view, the front view, this is what you see. While on the posterior or back view, you see the facets, two facets. So a facet on the left, for the lateral condyle of the femur, for attachment to the lateral condyle of the femur, and you have a facet on the right for the medial condyle of the femur. So from this, we appreciate that the patella is the largest sesamoid bone. It has a base, apex, and articular facets, and it functions to protect the knee joint, enhancing leverage of the quadriceps femoris muscle. And clinical issues regarding the patella include fracture or dislocation, which can significantly impair the extension of the knee. All right. So let's take a moment at this point to test our understanding of the pelvis, or what we have learned so far. And just so you know, there are 12 multiple choice questions in this lecture spread across this video. So I'll be giving a shout out in the next lecture to the first 5 students who drop all the correct answers in the comment section. So make sure to watch carefully, note your answers, and post them as a complete list once you've gone through the video. So let's see who gets it right and gets it fastest. Okay, so here's the first question. Which of the following bones is a part of the pelvic girdle? Think about, all of the bones. This is meant to be a very simple one. Okay, so is it the femur, is it the ilium, is it the tibia, or the patella? Think of it well, and then you know where to drop your answers, which explains why I won't readily revealing what the answers are now. And then secondly, as regards the acetabulum, in which bone is it located? Think of this carefully. Is it in the femur, in the ischium, in the hip bone, or in the pubis? Think of this very well. Okay. And then I have another question on the patella, or yeah. So what is the primary function of the head of the femur? Is it for muscle attachment, weight transmission, knee stabilization, or none of the above? And the fourth question is regarding the patella. So which of the following conditions is most likely associated with the patella? So is it dislocation or hip dislocation, tibial plateau fracture, or stress fractures? You can agree with me that these are just to also crack your ribs as well. So we'll come to other questions later. Now let's proceed into appreciating the tibia and the fibula. So these two bones are found in the regions of the leg. So the tibia, being the larger one, is medial. So you are looking at this is the anterior view. Okay, so the tibia is larger and is medial, and it's primarily the weight-bearing bone. Okay, it features a prominent malleolus down here. You have a shaft, and then you have the proximal end that has the condyles. So, and then you have the fibula, which functions primarily, for muscular attachment. Okay, it's the fibula is not a weight bearing. So let's appreciate the structures on each of them. So the tibia attaches proximally to the femur, right? So it does that through these condylar regions, right? So here is the medial condyle, okay, and here is the lateral condyle. Here is the medial condyle, and here is the lateral condyle. So we have an eminence between, or we have two eminences between both condyles. All right, so that's why they are referred to as a tubercle. Both of them are referred to as tubercles, and because and because you have them between both condyles, so they are called intercondylar tubercles. So it's easy to then separate the one that is closest to the medial part as the medial intercondylar tubercle, and separate that from the lateral intercondylar tubercle. Both of them make up the intercondylar eminence, right? So we also have a region just anterior to that eminence known as the anterior intercondylar area, and that's what you have right here. So here is the Gird's tubercle. You find that on the lateral condyle, anterior to the lateral condyle. Okay, so that's the Gird's tubercle. That's where you have the iliotibial tract inserting. And here, let's come a little more. You have a tuberosity here, and that's known as the tibial tuberosity. We also have a line on the lateral part of the proximal end, known as the oblique line of the tibia. So the tibia is here. Here is a shaft. So it has a lateral surface. It has an anterior border. All right, it has an anterior border and apparently a medial surface. So the anterior border separates both surfaces, and then it has a border on the medial end of that medial surface. So it has a border, yes, on the lateral end, okay, of the lateral surface. So there is something here known as the interosseous membrane in the complete human. All right, that is what attaches the tibia to the fibula. Okay, this interosseous membrane is right here, so that's why the border of the tibia that is next to that membrane, so it's not an empty space in a living person, right, or in a cadaver. So it has a membrane. So that's why that part is called the interosseous border, because it's next to the interosseous membrane. All right. So this is the medial, and when you come to the inferior part, you have the malleolus. All right. So the malleolus, the medial malleolus, which is that prominence you see on the medial part of your ankle, is formed by the tibia. So here is the medial malleolus, and then the opposite side, the lateral malleolus, is provided by the fibula bone, right? By the fibula bone. So here we can appreciate the inferior articular surface, right? The inferior articular surface with where the tibia and the fibula make the ankle joint along with the talar bone or the talus, which is one of the tarsal bones. So here is the medial malleolus, here is the lateral malleolus. So here is the articular facet of the medial malleolus, and here is the articular facet of the lateral malleolus on the inside. And speaking further, on the fibula now. So here is the fibula. So it has a lateral surface. It also has an anterior border like the tibia. So it has an anterior border, and which then separates which then creates a boundary between the lateral surface and then the medial surface of the fibula. And the part of the fibula, the border of the fibula that is next to the interosseous membrane, is referred to as the interosseous border of the fibula. And then going more proximally, the fibula also has a head, okay, which has on top of it an apex, and then it has a neck right here. So flipping this entire thing over on the opposite, and then we appreciate the posterior view of the tibia and the fibula. So we can see the intercondylar eminence here again with the medial, with the, yeah, so since this is the right uh, leg, bones of the right leg, so this is the right tibia. So when you flip it over, so this is the yeah, the lateral intercondylar tubercle. This is the medial intercondylar tubercle, contributing to the formation of the intercondylar eminence. And here is the so we saw the condyles anteriorly. Now we can see the articular surfaces here now. Okay, the articular facets the medial and lateral articular surfaces of facets, so of the tibia. So they are called the superior articular facets because the tibia has an inferior articular surface as well. Okay, unlike the fibula, which serves in the proximal end only as it joins to the tibia, but then it serves mainly muscular attachments. And we'll come to some clinical applications of fibula in a short while. So here is the superior articular surfaces or facets of the tibia, having the medial and lateral facet, and then here is the inferior. So we can see again the lateral condyle and then the medial condyle here. So this medial condyle has posterior to it the groove for the insertion of the semi-tendinous, the semi-membranosus tendon. Okay, and here is the soleal line, because for the attachment of the soleus muscle. So this is on the posterior. We had the linea aspera, right, in the femur. So in the tibia, you have the soleal line, and then you have the nutrient foramen again, allowing for passage of blood vessels through the bone. And so here is the interosseous border. It's to the right for the right tibia, and it's to the left for the right tibia, for the right fibula. Okay, so here's the posterior surface of the fibula. Here is the posterior surface of the tibia. So here is the medial border, and here is the lateral. So the lateral border of the tibia is also the interosseous border, while the interosseous border for the fibula is the medial border. Okay. So we also have the medial crest on the fibula. Yeah, it has a lateral surface and then it has a posterior border. Right, so here's the lateral malleolus and the articular facet of the lateral malleolus, articular facet of the medial malleolus, which is on the tibia here. So here is the groove for the tibialis posterior muscle for the their respective tendons rather. So the groove for the attachment of the tibialis posterior and the flexor digitorum longus tendons. And you have the fibula notch on the tibial bone. So that's the notch that receives the distal attachment of the fibula to the tibia. So with this, we've appreciated tibia being the larger and the medial of the bones of the leg. It's the major weight-bearing bone. It has medial and lateral. It has medial malleolus at the distal end. It has the tibial tuberosity at the proximal end, amongst other features. And the fibula is a smaller and lateral bone of the leg. It is non-weight bearing, so it essentially provides attachment for muscles, and it has the lateral malleolus on its distal end. So here again, we want to appreciate some of the other features. So the tibial tuberosity is more visible on the anterior side here. So here the cross section is better appreciated. The anterior border and posterior surface, anterior border, interosseous border, and then the medial border. So this is for the left tibia. Okay, so this is medial border. Yeah, so this is the left tibia, and this interosseous border is the lateral part of the tibia. Okay, and as for the fibula, so when you cut it at this point, and this becomes the anterior and this is the posterior, so you have an anterior border, a posterior border, okay, and then you have your interosseous border, or the interosseous. Yeah, so here is the interosseous border. So the entirety of here will be the posterior surface of the fibula. So here is the interosseous border, and here is the posterior border. So because this is the left view, the tibia will be on this side for this particular fibula. So it has a medial surface and a lateral surface. So you see the common fibular nerve running along this groove here. We've seen the medial part of the posterior surface, the medial surface, and you have the facet for the articulation with the inferior surface of the lateral condyle. Okay, like we said, the tibia will have been on this end in this picture. And so that was the proximal region, and here is emphasizing the distal regions, the distal relationship. So showing the posterior medial view of the distal end. And at this point, you can appreciate the articular surfaces of the tibia and then of the fibula, the malleoli, right? And here is how it forms the joint with the foot at the ankle joint. So here is the interosseous membrane we talked about. Here is still the tibia. Here is the medial malleolus. Here is the lateral malleolus. Here is the talar bone, the talus. Okay, this is the talus bone. We'll come to that when we discuss the tarsal region. So here again is the articular surface of the talus. This is the talus. Let's assume this is representing the talus here. And yeah, so here is the cut sections, right? The cross sections of both bones. So this being the lateral malleolus, which will always come from the fibula, and then the medial malleolus contributed by the tibial bone. Okay, so the articular surface narrows posteriorly, and here is the anterior region. So the articular surface widens anteriorly for the for this ankle joint, okay, and then it tapers posteriorly. So you can see this end is wider than this end. So the we want to appreciate the clinical relevancies of some of what we have talked about, and this particularly has to do with a function that the fibula serves. Okay, the fibula is, like we know now, is the thinner of the two bones in the lower leg. So it plays a crucial role actually in providing muscular support or muscular attachment, but it's frequently used in bone grafting, and that's what I've shown here. So it's used in bone grafting. So this procedure is usually um, occurring whenever you have the reason when you have a tumor perhaps in the tibia and you need a donor site to, or a donor bone to graft into the already problematic tibia. Okay, so it makes the fibula an ideal donor site for reconstructive surgery. The vascularized fibula transfer is what is happening here. So it's one of the most commonly used techniques for reconstruction of large tibial defects like you have here in orthopedic oncology, where an individual could probably have a cancer of the bone or a cancerous growth or a malignant tumor. So in this particular case, this is from a 16-year-old girl with a malignant tumor of the mid shaft of the tibia, seen here on the radiograph. Okay, so here's an X-ray showing the destructive lesion around here, and that has been cartoonized here. So here is a segmental resection of that tumor to remove the tumor. So once you remove the tumor, you have something like this. Okay, so in this third one, you can see the defect that is created by the removal of that tumor. The tumor has been removed, then there's some part of the tibial bone had to go with it. Okay, so similar to what is happening here. Okay. So what happens next is an example of reconstruction. okay, using the vascularized fibula within allograft bone. So in this case, they use what is called the Kapana procedure, right? So you graft the tibia, the fibula, and then it's brought into where the tibia used to be, and that leaves the fibula incomplete. And that's what has led to this point where we now have the reconstruction, inside to using vascularized fibula and allograft, right? So to this end, it's, successfully, you now have a post-operative X-ray image showing what happens. So you can see the incomplete ends of the fibula, and then you have the completed tibia, right? So here is a 3D computed tomogram of reconstruction showing the fibula enclosed by the allograft bone. And in case you're wondering, tibia is often chosen for bone grafting because it's primarily a non-weight bearing bone, meaning that its removal or partial removal does not significantly compromise the person's structural stability, or the stability of the leg of the patient, or even the patient's ability to walk or bear weight. None of that is going to be affected. And the reason why that is possible is, first, because of the functional role. It mainly provides muscular attachment. Other than the fact that it forms the ankle joint, you know, it does not play a major role in bearing weight, and the tibia handles that responsibility fully, and that's why it's that big. After harvesting, the remaining fibula is still there. The remaining fibula, after harvesting the graft that is needed, the remaining fibula is still left there. It's not the entire thing that is removed. So the remaining fibula and the surrounding structures can adapt, to maintain the leg's overall function. And thirdly, it's a selective removal, in the sense that surgeons typically remove a section of the fibula, not the entire bone, for the grafting. So this ensures minimal disruption to the ankle joint, because you still leave part of it to form the ankle joint and ligament attachment. So, however, careful surgical planning and post-operative care are usually critical to avoid complications like ankle instability, weakness in muscles that are attached to the fibula, gait abnormalities in extreme cases, or even patients that typically find it difficult to recover because an error accrued in some of these issues. So, if all these observations are taken seriously, patients will recover well with proper rehabilitative support. So we've appreciated that. Another thing that tends to happen, particularly, is fracture in the mid shaft of both the tibia and the fibula, and this is something common in skiers. So yeah, until we start having snow in this part of the world, you probably aren't familiar with ski, except you have experienced that in other parts of the world. Okay, so it's particularly common in skiing, where there is high-speed twisting forces or sudden impacts that could lead to these injuries. Okay, so in such cases, both bones are often fractured simultaneously due to their close anatomical proximity, and they share, the exposure to the stress. So this dual fracture scenario demands full alignment during the treatment in order to restore the proper length. Complications like malunion or instability. So for the next question, and you remember where to drop the answers. We're asking now, on the medial malleolus, it is part of which bone? The medial malleolus, is it part of the tibia or the fibula, the femur, or the talus? And the which bone provides attachment for muscles but does not bear weight? Which bone is that? Does that sound familiar? You know where to drop your answers. Remember, we have come across 6 questions now. Next to be discussed is the tarsal bones. The tarsal bones. The tarsal bones are very crucial for foot movement and support. Okay, so let's quickly go through some things. So here is the foot when you're looking at it from the top. So this is what we call the dorsal view. Okay, this is what is called the dorsal view. And when you are looking at it from underneath, that's the plantar surface. Okay, and that's what we call the plantar view, right? So chiefly showing here the tarsal bones. We have one of them known as the talus, which is what we have here. We have the calcaneus, which is underneath here. So the talus articulates with the tibia and fibula proximally on top, okay, to form the ankle joint. As for the calcaneus, it's the largest tarsal bone. It forms the heel. It forms the heel. You can appreciate that from while looking on the from the underside here. The navicular bone, okay, so named because of its shape, like I mean, it takes the shape of a sheep, you know, as you wish. So it's located between the talus bone and another set of tarsal bones we refer to as the cuneiform. Okay, so here is the navicular bone, right? The navicular bone. So you can appreciate that from the underneath as well. We've seen the calcaneus, we've seen the talus, in the navicular. Okay, next is the cuboid. From the underside you can see that here, and from the dorsal surface, from the dorsal view, you can see that here. So it's the lateral tarsal bone that articulates with the calcaneus posteriorly. All right, and then the fourth, it attaches to the fourth and fifth metatarsals anteriorly. You can see that here as well. Fourth and fifth metatarsals anteriorly, and then the calcaneus posteriorly. So that's the cuboid. The cuboid is a lateral tarsal bone. The navicular is a medial tarsal bone. And finally, the cuneiforms. The cuneiforms. So these cuneiforms, there are three of them. You see them in a line, both dorsally and plantally. So the most medial of them is called the medial cuneiform. The most lateral is known as the lateral cuneiform, and that's the one that is next to the cuboid. And then the one in between those two is known as the intermediate cuneiform bone. So you can see for that, as for the calcaneus, it has a body. So this is the body of it. Okay, so this is the body of the calcaneus bone, and then you have the fibula. So here in the talar bone, here are the posterior processes. Okay, so the talar bone, that or known as the talus, it has a lateral tubercle. Remember, this is the right foot. Okay, this is the right foot. So this is the medial region and this is the lateral region of this right foot. We are looking at it from the top here. So here is the lateral tubercle and here is the medial tubercle. This is a posterior process. We also have a groove for the tendon of the flexor hallucis longus, which helps to flex the big toe, right? It helps to pull it downward. So that groove, that tendon passes through here. So we see this groove. So these three are the posterior processes of the talus. Now here is the trochlea, so more like the wedge that forms the ankle joint along with there's a surface that attaches to the tibia as well as the fibula. Okay, so here is the trochlea. The surface is the trochlea, and then the talus is still what extends down here, and this is where we refer to as the neck of the talus. And here is the head of the talus. So it's the head of the talus that comes in contact with the navicular bone, right? So here is a space known as the tarsal sinus. It's the tarsal sinus. Okay, this is the tarsal sinus. And then there is what we call the transverse tarsal joint. The transverse tarsal joint. So that's the joint that it's the joint you have between these two, that joins these two tarsal bones to the rest of the tarsal bones that you have here. So Here is the tarsal metatarsal joint. That's the joint between the entirety of the tarsal bones and the metatarsals. That's the tarsal metatarsal joint. While here is the transverse tarsal joint. It's more like the joint that divides the entire tarsal bones into two categories. You have some anterior and some posterior. So those posterior ones will be the calcaneus and the talar and the talus in this case, and then the anterior ones will start from the cuboid, navicular, and then the cuneiform bones. Okay, so here is the cuboid again, and we see the navicular bone here, and the navicular bone also has a tuberosity, so that's the navicular tuberosity. What else do we have here? There is the metatarsal, so we'll come back to those in a while. This is the dorsal view, and then on the ventral end, pardon me, the plantar end or the plantar view, here is the calcaneus bone again, and here is the tuberosity. So on the inferior side, it has a medial process and a lateral process. Okay, medial and lateral. Remember, this is the right foot, and so this is the medial, and then this is the lateral region, because now we are looking from the ventral side, I mean from the plantar side. So here is the medial and lateral process, and still on the calcaneus, you can see here a groove for the tendon of the flexor hallucis longus that we saw the other time. Okay, that it's passing here. Okay, so here is the groove for that tendon, and then this region, this area, is known as the sustentaculum talus or tali, the sustentaculum tali. So that's the part where the talus sits on the calcaneus bone, right? So this part we have seen is the calcaneus, while this part here is the talus. So the talus, we can see the lateral tubercle here, the medial tubercle. Okay, so that's flexor hallucis longus that was coming from here. Okay, so it comes and passes through here on its way to attach to the first digit, or to the first toe. So we have the head here, and we've seen the trochlea here. So here is the head of the talus. You have the posterior process, and then the medial tubercle of the which is the talar part of the foot, right? So we can see here the transverse tarsal joint on the inferior or the plantar view. So here is the navicular bone and its tuberosity. Here is the cuboid bone with its tuberosity, and then a groove for the fibularis longus tendon. All right. So the lateral, intermediate, and medial cuneiforms, the tarsal metatarsal joint. All right, the tarsal metatarsal joint. So with this, we've okay. So that was the talus or the tarsal bones. Now for the metatarsals, these are the 5 digits. Okay, these are the 5 digits: 1, 2, 3, 4, 5, and each of them has a base, a shaft, and a head. Right, a base, a shaft, and a head. 5 of them like that: a base, a shaft, and a head. And you also have the phalanges. So the first, as for the metatarsal, the first metatarsal is the thickest and the strongest. Okay, and then as for the phalanges, they also have a base, a shaft, and a head. A base, a shaft, and a head. So there are 3 of them. In each, you have 3 phalanges each on each digit. So each digit has 3 phalanges, except for the first digit that has only 2 phalanges, and each phalanx Phalanx is the singular, phalanges is the plural. So each phalanx also has a base, a shaft, and a head. So here are the proximal phalanges, here are the middle phalanges, and here are the distal phalanges. But for the first digit, there is only a proximal and a distal phalanx. Okay, proximal and distal phalanges. So base, and then the tip of that you have a tuberosity. So you can appreciate that here as well. The base, the shaft, and the head, base, base and head for the other smaller ones. You know, as this the smaller they become, the shorter their shaft. And then you have on the dorsal region of the first metatarsal, you have two sesamoid bones, the medial and the lateral sesamoid bones, okay, on the distal end of the first metatarsal bone. So with this, there are a number of clinical correlations that apply to this, and this includes the Lisfranc injuries and stress fractures. So, speaking more of the stress fractures, as a result of repetitive stress on the foot, the second and the third metatarsals are usually affected. So, the metatarsal and the phalangeal bones could experience a number of injuries. We just concluded talking about the strong injury in the previous slide. So that refers to any injury that involves damage to the strong joint complex. And the strong joint is another name for the tarsal metatarsal joint, the joint between the metatarsal and the tarsal bone in the midfoot. So it was named after the French surgeon Jacques Lisfranc, who worked a lot to stabilize the that joint in patients that had issues with it. So the injuries could range from fractures to strains to dislocations, amongst others. So the metatarsals themselves, the injuries to them happen also commonly. So it's between the ankle and the toes. So these fractures are quite common, and they could be acute, they could be stress fractures, they could be displaced fractures. The acute ones are those sudden breaks that are caused by something dropping on it or severe twist, while the stress fractures refers to some small cracks that result from repetitive force or overuse of those regions. Displaced fractures occur where you have bones end up not lining up correctly. So this could be resulting from heavy drop of objects on the foot, twisting the foot during sports, overuse in activities like running or jumping, or poorly fitting footwear. Okay, and the symptoms that could usually emanate from this will be some sharp or aching pain at the time of the injury, especially for the acute ones. And then there could be swelling and bruising on the top of the foot for a longer lasting one. And then there could be difficulty walking or in bearing weight. So a common treatment option will be to rest and then to place ice so to reduce the swelling and support recovery. One could also be treated through immobilization by wearing a cast or a boot to keep the foot stable. So to also keep the foot raised to reduce the swelling, or in very advanced or complicated cases, surgery may be required for severely displaced fractures to realign or restabilize the bones. So here is an example of a well cushioned shoe, which is used to also keep the foot supported. So it's one of the type of shoes used in the therapy, physical therapy, that is that aims to restore the normal functionality or normal activities of the foot. So well-cushioned shoes help to aid the recovery process. So we're back to questions now. This time around, question 7, and I'm asking which tarsal bone forms the heel. The heel, okay. Which tarsal bone forms the heel? Is it the talus, the navicular, the calcaneus, or the cuboid? And question 8, the trochlear surface of the talus is involved in the formation of which joint? If you remember, is it the knee joint, the ankle joint, the hip joint, or the subtalar joint? So think well and drop your answers in the comment section. I have another question, and that's regarding the hallux, right? So how many phalanges are present in the hallux? That's a big toe. Is it 1, 2, 3, or 4? And which metatarsal is the strongest and the thickest? Is it the first, the second, the third, or the fourth? I'm expecting your answers. So let's go into something further interesting about the foot, and that's the foot arches. So on a medial view, this is what the arches of the foot look like, right? Then on a plantar view, when you're looking from the underside, these are the footprints that are created by those feet and the arches. And then when you are looking posteriorly, this is what the foot looks like. So first of all, we should know that the foot has about 3 arches. One of them is transverse. So this is a transverse arch, okay? And this is also depicted here. While 2 of them are longitudinal arches. So running from both sides of the feet anteriorly down to the almost the sole of the foot posteriorly. So the longitudinal arch that is medial is the medial longitudinal arch, and then the lateral longitudinal arch. And then here are the bony references. So from the tip of the, or let's say from the head of the first metatarsal to the head of the 5th metatarsal down to the posterior end of the calcaneal bone. All right, so this is the triangle that is created from the arches. So here are the heads of the metatarsal, and midway here you have the cuneiform bones, okay, and then bordered on the lateral part by the cuboid, as you can see here. So what we refer to as an individual having a flat foot is when the medial arch is too low. So that produces a flat foot, as you can see here. And this will be the footprint of such individual, and this is what it will look like on the medially. Okay. Then when the medial arch is averagely heighted, so that's the normal foot when the person has a medium arch, and this is usually the footprint. Whereas when when the medial arch is too high, right, that produces what is called a high arch or a hollow foot. So we appreciate here that we have 3 arches, and the functional significance of these arches is the fact that they help to distribute body weight, and they act as shock absorbers. So conditions like flat foot, high or high arches can usually lead to pains or gait abnormalities. Okay, so flat foot is otherwise known as pes planus, while high arch or hollow foot is otherwise known as pes cavus. So it's more like it's forming a cave. Okay, why the place planus is like the pes is the foot anyway, so planus is like it's plain. So there's usually a common word to steal in understanding some of these Latin vocabularies. Okay, take note of that. So let's evaluate your understanding of the tarsal bones and the foot arches. So for the first question, uh, think about, I mean, the calcaneus. So what's it also known as? It's known as the heel bone, the ankle bone, the navicular bone, or the cuboid bone. And my second question is about the function of the foot arches. So which of the following is the function of it? Weight absorption and distribution, increasing surface contact with the ground, muscle attachment, or protection of the knee joint? Feel free to drop your answer as expected. Okay, so going more into developmental clinical relevancies now. The long bones usually they arise through what we call the uh, endochondral ossification. There are two types of bone ossification. So you have the endochondral ossification and then the intramembranous ossification. An intramembranous ossification means that the bone is forming directly after the mesenchyme differentiates. The mesenchyme differentiates directly into osteoblasts. Okay, and these osteoblasts will end up releasing osteoids, you know, and then you have calcium deposition, and then bones form directly. Okay, without having to first of all become cartilages. But in the case of endochondral ossification, in that case, unlike in intramembranous ossification where you have direct bone formation, in endochondral ossification it's known as a cartilage model. So in this case, you have cartilage model preceding bone formation, and then eventually you have the bone replacing the pre-existing cartilage template. So the thing is that lower limb bones develop through endochondral ossification, right? So the intramembranous ossification usually forms flat bones like the skull, the clavicle, and parts of the mandible. So bones like this, you have mesenchymal cells differentiate into osteoblasts. The osteoblast secretes osteoid. The osteoid calcifies as calcium salt gets deposited, and then you have the bone tissue form. That's meant for flat bones, right? But for long bones, which usually still need to develop as you age and then you increase in height and all that. So the mesenchymal cells first of all differentiate into chondrocytes to form a cartilage model. And thereafter, the central chondrocytes that are in the middle, they enlarge and then they die, creating cavities, the empty holes you find within the cavities of the long bones. And then blood vessels invade those cavities, you know, thereby introducing the osteoblasts that will end up replacing the cartilage model, okay, the cartilage with the bone matrix. So there are usually two ossification centers for these bones, So the primary ossification centers usually develop in the diaphyses, that's in the shaft of the bones. Okay, the primary ossification centers develop in the shaft of the bones, the middle of the bones, while the secondary ossification center develop in the epiphyses at the tips of those bones. So as you can see here, the primary ossification of the lower limbs, you know, primary ossification occurs, of course, prenatally. So the ossification centers appear prenatally in the fetal age before the child is born. So for the femur, primary ossification center that will appear in the diaphyses appears between the 6 to 12 gestational weeks. For the tibia, 6 to 12 weeks as well. For the fibula, 6 to 10 weeks. And then for the talus, calcaneus, metatarsal, you know, they appear at this respective number of months. While the secondary ossification center, you know, for the femur is usually within appearing between the 6 to 10 months. So during this secondary ossification, you know, the growth plates, that's the epiphyseal plates, they remain there for bone lengthening until adulthood. So that's the beauty of endochondral ossification. So it supports bone lengthening through childhood, adolescence, and it's very crucial, you know, for skeletal growth. But for intramembranous ossification, it occurs early in prenatal development. So yeah, so we appreciate this now about the key timelines. And now An important clinical correlation, like I alluded to at the beginning of the lecture, is developmental dysplasia of the hip, right? And this is where when you have the femoral head failing to align with the acetabulum. Here is the healthy hip, the normal hip. So you will find that in some children, unfortunately, the femur is dislocated. Look at the hip socket. Look at the acetabulum. So this is dysplasia. Okay, so where the femoral head fails to align with the acetabulum, and it highlights the importance of proper bone development. So anatomical variations refer to deviations from the typical anatomical structure that are usually harmless, but occasionally they cause problems. Symptoms under certain conditions, like when there is an overuse or when there is trauma. And example of those is the bipartite patella you have here, which is a condition where the patella, which is the kneecap, okay, is composed of two separate bones. Okay, bone fragments. You can see the two separate bone fragments here due to incomplete fusion during development. So typically it's asymptomatic. It doesn't produce a symptom of pain or so, but it may cause pain when there is a repetitive knee activity. The person may start to feel that. So you never can tell why you're feeling that pain. So another condition is accessory bones, where you have extra bones like the ostrigonum that is found behind the ankle joint here. So it arises from unfused ossification centers. And these are often incidental findings, but it may contribute to pain or impingement in specific activities. So furthermore, we have genu of different status. Genu refers to knee. Okay, so the normal knee would look like this. Okay, the normal knee would look like what we have here. But when there is a deviation, it can be a genu valgum or a genu varum. Genu, I guess. Yeah, genu. So genu valgum or genu varum. So in the case of genu valgum, you can see the knees are touching. That this is what is called knock knees. The knees are knocking on each other. So it's a variation where the knees angle inward. Okay, they angle inward, causing increased stress on the lateral structures of the knees. So a lot of stress is on the lateral structures of the knee here during this knock of the knee. So genu valgum. So valgum. We had coxa valga the other time. So now it is called valgum because the noun that it is serving as an adjective for is, in this case, they call this a neuter. Yeah, they call this neuter in Latin. I'm a student of language as well. Yeah, so um, Latin words can be masculine, feminine, or neuter. So masculine words are like those that end with us, like the humerus, the radius, you know. So while feminine words end with a, like the coxa that we talked about. So in the case of coxa, the valg there will be valga, coxa valga. But in the case of the genu, which is neuter, the genu is it's not ending with us like masculine word. So genu is considered a neuter, that it is neither masculine nor feminine. So genu valgum. So coxa valga. It's the same word, only that you have to deflect it based on the grammatical rules of the Latin language. So genu valgum here means it's angulating, it's opening up outside, so to speak. So there is increase in angulation. Remember, coxa valga is when you have an increased angulation, so more like there is a widening of the space you have between the neck of the femur and the shaft of the femur. So when it widens, that is valga, coxa valga. Coxa is angle, so or indentation. So coxa valga. So in this case now, The genu is valgum because it's creating an indentation, it's widening the indentation outside. So that is coxa, that this is genu valgum, not knees. While on the other end, you have the genu varum. So it was vara in the case of coxa. So coxa vara, here it is genu vara, in the sense that we have an angulation where it's decreasing, so decreasing inward now, right? So here, where the knees angle outward, or it angles outward, but it's creating a angulation inward. So it leads to stress on the medial structures of the knees. Right? So while most anatomical variations do not interfere with functions, they actually can influence biomechanics and predispose individuals to certain conditions when subjected to repeated stress. So there could be lower limb length discrepancies too, and then we've talked about the genu, valgum, and varum. So imaging plays a crucial role in diagnosing fractures, dislocations, and degenerative changes. So X-rays are the most commonly used modality, which is what has produced this image that we have here. Okay, so it offers views like the anterior-posterior, like we are seeing here, and then lateral projections. CT scans also provide detailed 3D reconstructions, while MRI are quite invaluable for assessing soft tissues, to see the state of the muscles and what have you. So it's important. The imaging modalities are very important in identifying the fracture patterns, the dislocation, and degenerative changes that are going on in the lower limb. So, to conclude our learning assessment, here are some questions on developmental aspects that we just concluded, as well as anatomical variation. So, this is the first of them, and it becomes our 13th question for this lecture series. It's asking, endochondral ossification is the primary mechanism for the development of what? Skull bones, long bones, sesamoid bones, or flat bones. And this is the 12th and final MCQ question. So, which anatomical variation is associated with the patella? Is it a bipartite condition, genovarum, accessory navicular, or pes planus, right? Yeah, if you enjoy tougher questions like we intend to subsequently, you'll meet them in some further videos. So these are questions to help juggle your memory. So this is the 12th and final MCQ in today's lecture. Remember, I'm expecting to see you complete answers to all the 12 questions in the comment section. So you don't give the question separately. You put the entire question as one post or one single entry into the comment section. Don't forget, the first 5 students to get all the answers correct will get a shout out in the next lecture. So make sure to submit your answers on time. So to summarize, the bones of the lower limbs are designed to support the weight of the body and enable efficient locomotion. We've gone through the structural and functional aspects of the pelvic girdle, the femur, the tibia, the fibula, and the foot. So we also touched on the clinical correlations of each of these bones, and we've emphasized the importance of the arches and ossification in clinical practice. So the tibia is the main weight-bearing bone. We appreciate that, while the fibula provides, muscle attachment. The tarsal bones form the ankle and the heel, and then you have the metatarsal and phalanges helping in foot structure and foot movement. So I want to thank you for your attention, and I hope you've gained a deeper understanding of lower limb anatomy. So that's it for today's lecture. Thank you for watching and engaging. I'll look forward to your comments with the correct answers to all the 12 MCQs. Remember, the first 5 students with the correct answers will get a shout out in our next lecture. So don't delay. Get your answers in as soon as you can. And until next time, I wish you all the very best. Stay curious and keep learning. See you in the next class. Bye.